Good afternoon. Talking about interesting new trends, I will share our experience about radiofrequency ablation of the main pancreatic duct, both in patients and animals. Occlusion of the main pancreatic duct is in fact an old procedure, but sometimes forgotten. It can be done by any means, like suture, glue, or whatever, and lead to a complete atrophy of exocrine pancreas and preservation of the endocrine one, and always without pancreatitis. That is a very important event, but not all pancreatic surgeons are well aware of it. And in fact, in the history of the management of pancreas diseases, there has been many attempts to occlude the main pancreatic duct to avoid pancreatic fistulas after PD, or even to treat other pancreatic disorders. In the early days of PD, Whipple himself used occlusion with sutures to occlude the main pancreatic duct because it was deemed to be less risky than pancreatic anastomosis. But in any case, pancreatic fistula was quite common. There has been also several high-quality randomized clinical trials comparing occlusion of the main pancreatic duct with pancreatic anastomosis, demonstrating similar morbidity, similar pancreatic insufficiency, and perhaps higher risk of diabetes. In any case, obstruction of the main pancreatic duct remains today an accepted procedure in difficult circumstances. Specifically in that indication, Massaferro has recently published in Annals of Surgery a clinical trial in which he employed occlusion of the main pancreatic duct in case of high risk of fistula in comparison to low risk, and he could not see many differences in terms of pancreatic fistula. For many years, we, as many others, have been working both in the animal setting and also in the clinics with radiofrequency ablation as a means of sealing the main pancreatic duct, like in this case, in which a pancreatic transection was performed by a radiofrequency assisted device, which name is Cullen-Biss, in which we achieve stenosis and fibrosis, like this, of the main pancreatic duct, avoiding pancreatic fistula. In fact, nowadays, we are embarked in an ongoing randomized clinical trial in which this system is being compared to a staple in distal pancreatectomy. In the animal setting, we have published in scientific reports of Nature that endoluminal radiofrequency ablation with a catheter of the main pancreatic duct is safer and more efficient than glue, in any case, avoiding the pancreatic fistula. Even more important, maybe the oncologic implications of all that. As you probably know, there are Carras models that reproduce the sequence of preneoplastic lesions in the pancreas and malignant tumors. In that very context, we have also recently demonstrated that occlusion of the main pancreatic duct can avoid these pre-malignant lesions in the pancreatic stump and may interrupt the progression to adenocarcinoma in transgenic Carras. Keeping all in mind, we have employed radiofrequency ablation or Virsun to manage the pancreatic stump after Whipple in an approved clinical trial in high-risk fistula cases like this, or after in extremely soft pancreas, with small ducts, lung operations, or reoperations like this. So far, we have operated on 8 patients, and our preliminary results have been published last year in this journal. This is a clip in which the radiofrequency catheter is introduced into the main pancreatic duct. You can see the electrode, the ablation that produced in just 20 seconds with a higher temperature, about 100 degrees, and the removal of the catheter. There are here some representative images before and after the procedure in which the ablation of the main pancreatic duct is clearly seen, and the atrophy afterwards, atrophy of the pancreas. There are some proofs that after ablation, all occurs in a quantitative way. In each patient, we can initially measure the ablation of the main pancreatic duct, and with time, this disappears, leaving behind the stenotic duct in order to avoid fistula. The principle is no duct, no fistula. In these patients with occlusion of the main pancreatic duct, there is, as I have said, no pancreatitis. You can see here some slight elevation first day of the serum lipase after radiofrequency ablation and normalization afterwards. So far, we have not seen mortality, no reaberration with this procedure, and we are confident that in some cases, it can be very useful to control high-risk fistula. In order to improve our results, we are currently testing the procedure endoscopically through the papilla, like this, in the animal setting before the Whipple procedure, in order to get a complete atrophy, to complete obstruction of the duct. With the obvious discretion of a new trend, we can envision two indications: as a method to produce pancreatic atrophy, to avoid pancreatic fistula after Whipple, and to trigger a physiological protective effect to avoid malignancies in pancreas harboring several pancreatic diseases with KRAS mutations. Thank you very much.